Welcome to the Advancing Chronic Care with Effective Scalable Solutions, or ACCESS, Model Primary Care Practitioner and Referring Clinician webinar. Thank you all for joining us today. Next slide, please. Before we get started, we will share some brief housekeeping remarks. During today's presentation, all participants will be in listen-only mode. We recommend that you listen via your computer speakers, but we also have the option to dial in from your phone. The dial-in information is available on the screen. Today's presentation is being recorded, and closed captioning will be available at the bottom of your screen. Additionally, at the end of the webinar, you will be directed to a brief survey to collect your feedback on the event. Next slide, please. Now we will review our agenda for today. First, we will begin with welcome and introductions. Then, we will use our time to provide an overview of the model, review the model's care coordination features, and the co-management payment approach. Then, we will answer common questions submitted through event registration in the help desk. Please feel free to submit any questions you have in the Q&A box throughout the event, and you can find that at the bottom of your screen. We will also welcome you to email the ACCESS team at accessmodelteam@cms.hhs.gov. We'll share this email address in the chat here. This slide deck, along with a recording and a transcript of today's event, will be available on the ACCESS Model webpage in the coming weeks. I will now pass it over to Pooja Nair, the ACCESS Model co-lead, to provide opening remarks. Next slide, please.
Hello, everyone. My name is Pooja Nair, and I'm one of the co-leads for the ACCESS model. On behalf of CMS and the CMS Innovation Center, thank you for joining us today for this session. As part of the CMS Innovation Center, we develop and test new healthcare payment and service delivery models that are designed to improve patient care and affordability. We're excited to share this webinar on the ACCESS model, which is a nationwide 10-year voluntary innovation center model starting on July 5th, 2026. The ACCESS model tests an innovative outcome-aligned payment approach in Original Medicare to expand access to new technology-supported care options that help people improve their health and prevent and manage chronic disease. Historically, patients with Original Medicare have had limited access to technology-enabled care services for managing their chronic conditions because of Medicare payment barriers. ACCESS is designed to address these barriers by introducing an innovative payment option that focuses on measurable health outcomes rather than just paying for activities. Patients with Original Medicare can sign up with participating ACCESS organizations either directly or through a referral from their primary care practitioner or PCP or another referring clinician. For PCPs and referring clinicians, ACCESS is designed to strengthen care coordination by supporting timely electronic sharing of care plans and key patient updates, which are capabilities that we'll walk through during today's event. To support coordinated care during ACCESS, PCPs and referring clinicians may bill a co-management payment, or CMP, without beneficiary cost sharing for reviewing patient updates and documenting related care coordination activities. Next slide, please. Now I'll introduce the rest of today's speakers. As I mentioned, my name is Pooja Nair, and I'm one of the ACCESS model co-leads. I want to acknowledge Nora Connor, who's my co-lead. She wasn't able to join us here today, but is putting out fires as we march toward a launch in launch in a month. I'm joined today by Anna Rabel, who is the ACCESS model quality lead, and Coleman Adams, who is the ACCESS model payment lead. Next slide, please. We'll begin by reviewing information about the ACCESS model. Next slide, please. So despite compelling evidence that technology-enabled care works, many patients with Original Medicare still cannot access these options due to a lack of reimbursement through traditional Medicare. For clinicians who are interested in technology-enabled care for their patients, the current Medicare payment structures often limit what they can realistically offer. Through ACCESS, CMS is testing a new outcome-aligned payment, or OAP, option that prioritizes results over activity volume. ACCESS strives to give technology-enabled care providers and organizations more flexibility to use innovative technology-supported delivery models that improve patient health and complement traditional care processes. So there are 4 goals for the ACCESS model. The first, ACCESS empowers patients to achieve their health goals by improving access to new technology-supported care options. Original Medicare, as I've mentioned, has historically lacked a payment pathway to adequately support novel technology-enabled care. Fee-for-service pays for a defined set of activities that don't align with the way technology-supported care is delivered, which can be continuously, remotely, and often asynchronously, so not just in a doctor's office. Second, Access promotes clinician-guided, accountable, and coordinated technology-enabled care by creating a straightforward payment pathway for organizations that currently lack viable reimbursement options in Original Medicare. By rewarding outcomes rather than volume of services delivered, Access gives these organizations greater flexibility to deliver continuous, integrated chronic care using modern technology-supported care. Third, Access drives choice and competition by promoting transparency of participant performance. CMS will maintain a public directory on Medicare.gov listing all Access participants, their tracks, and conditions they treat, as well as their risk-adjusted outcomes once available. This transparently empowers patients and referring clinicians to make informed choices about which Access participant is the best fit for their needs. Finally, Access protects federal taxpayers by conditioning full payment on clinical outcomes. Participants earn the full payment amount only when patients meet measurable health goals, such as lowering blood pressure, reducing hemoglobin A1C, or achieving meaningful improvement in chronic pain or depression symptoms. This approach ensures Medicare pays for results that prevent costly complications and not just activities. Each of these goals align with the CMS Innovation Center's mission to test innovative healthcare payment and service delivery models that have the power and potential to lower Medicare spending while maintaining and improving the quality of patient care. Next slide, please. So before we get into more detail on the Access model, we'll provide a quick overview of the clinical tracks for this model. Access addresses high prevalence, high cost chronic conditions affecting millions of Medicare beneficiaries through 4 clinical tracks that group clinically related, frequently comorbid conditions. The conditions in these tracks affect more than 2/3 of people with Medicare. Access participants are responsible for managing all qualifying conditions that a beneficiary has within a track, which aims to support integrated patient-centered care. So now just walking through each track, the early cardio-kidney metabolic or ECKM track targets early intervention to prevent disease progression. Qualifying conditions include either hypertension or 2 or more of the following, including dyslipidemia, which is abnormal lipid levels, including high cholesterol, obesity or overweight with a marker of central obesity, and prediabetes. And the key here is early. We're really focusing on prevention before conditions advance. The next track is the cardio-kidney metabolic or CKM track, which addresses more advanced cardio-kidney metabolic conditions with higher clinical complexity, including diabetes, chronic kidney disease, and cardiovascular disease. The musculoskeletal or MSK track includes chronic musculoskeletal pain, and finally, the behavioral health track includes depression and anxiety. Next slide, please. In addition to Access participants, PCPs and referring clinicians play a central role in the model. Access offers a pathway for these clinicians to support patients with chronic conditions while staying actively engaged in ongoing care management. PCPs and referring clinicians can refer their patients to Access participants who they'll be able to identify via a publicly available Access participant directory. The directory will include information on the conditions that these participants treat and their risk-adjusted outcomes once they're available. Once a beneficiary enrolls with an Access participant, PCPs and referring clinicians can incorporate Access-supported services into the patient's broader care plan in several ways. First, Access participants are required to share care updates to patients' PCPs or referring clinicians at the start of the care period, at care completion, and when a clinical escalation occurs. Clinical escalation indicates that beneficiaries are being unaligned from the Access model. And just to clarify responsibilities here, participants are not going to be issuing updates every time a participant changes medications or has a similar routine change. It's just during those critical periods at start of care, at care completion, and when a clinical escalation occurs. These care updates will be shared via a HIPAA-compliant method. This includes direct secure messaging and eFax. Second, Access participants are required to connect to a Health Information Exchange, or HIE, or an alternative CMS-aligned network no later than July 2027. This applies to Access participants. This will ensure that structured updates can be shared with PCPs and referring clinicians. Through a trusted network, providers will be able to access patient information that they need to understand patient care being provided. The model is designed to balance a baseline level of structured push updates, which are the care updates, from access participants to referring clinicians and PCPs at care initiation, escalation, and completion, as I mentioned, while also enabling pull updates for providers to access patient information through required access participant connectivity to an HIE or an equivalent trusted network. Finally, PCPs and referring clinicians can bill for an access co-management payment, or CMP, when they review patient updates from the access participants and document accordingly. We'll be discussing the CMP in further detail later in this presentation. Next slide, please. This slide shows how care coordination works within Access. The patient is at the center of the model and enrolls in Access for chronic care directly through an Access participant. Patients may also receive optional enrollment support from a PCP or referring clinician, and they can use the Access Participant Directory to identify available options. After enrollment, the Access participant shares care updates at key points throughout the care journey. As I've mentioned, that's start of care, escalation of care, and care completion. At the start of care, Access participants can share the care plan and the patient's baseline measures. If the care is escalated or transitioned, updates are shared during that process, and at the end of the care period, a summary of care is provided. These care updates are transmitted through a HIPAA-compliant electronic method. In parallel, on the other side, Access participants share clinical data with the PCP or referring clinician. This data include biomarkers, patient-reported outcome measures or PROMs, and medication information, which can all be accessed by querying a CMS-aligned network HIE. Based on receipt and review of care updates and clinical data, the PCP and referring clinician may bill a co-management payment for care coordination and related review activities. Access participants can also bill outcome-aligned payments for treating qualifying chronic conditions. Next slide, please. This slide shows how Access supports patient care by offering providers new covered options through Access participants helping patients in their care journey. As an example, we'll use a patient profile, totally hypothetical, involving an original Medicare beneficiary with low back pain and moderate depression who presents to their PCP for a routine checkup. The PCP has already prescribed the patient a selective serotonin reuptake inhibitor, or SSRI, which is a type of antidepressant medication, as well as a medication for back pain. The PCP has also encouraged the patient to find a therapist, but the patient still needs additional support. Thanks to Access, the PCP will be able to offer their patient new covered services. To identify the best options, the PCP will use the Access Participant Directory to find organizations in the MSK and behavioral health tracks offering services that are a strong fit for the patient's needs. They identify an Access participant who provides services that fit the patient's needs. Then the PCP and patient work together to enroll that patient by signing up directly with the Access participant. The PCP then receives a care plan from the Access participant for their patient and can access patient data, including some of those metrics I mentioned earlier, so biomarkers, PROMs, and medications where applicable, in their workflow via HIEs or CMS-aligned networks. The PCP bills Access for co-management payment and additional payments for assisting the setup and onboarding processes. This example helps illustrate how Access provides patients and PCPs with options to support effective and coordinated care. Next slide, please. Now I'll just briefly walk through key dates in the model timeline. The model will launch on July 5th, 2026 and run for 10 years. Accepted applicants for the model's July launch can be found on the Access model webpage, which CMS continues to update. There will also be a forthcoming Access participant directory that providers and beneficiaries can use to view a full list of Access participants. PCPs and referring clinicians do not need to apply or enroll in the model in order to participate as a PCP or referring clinician that has, as I've mentioned, existing in the healthcare ecosystem, supporting the beneficiary that's aligned to an Access participant, receives those care updates, etc. Importantly, beneficiaries can enroll throughout the duration of the model. I'll now pass it over to Anna, who will be speaking to the next section on care coordination. Next slide, please.
Thank you, Pooja. Now we will discuss care coordination in the access model and how and when clinicians will receive updates about their patients from the access participants. Next slide, please. The access model creates an opportunity for clinicians to better support patients with chronic conditions by offering affordable, new care options while allowing PCPs to remain the central coordinator of care for their patients. Access participants share clinical information with PCPs and referring clinicians to help them make more informed care decisions for those patients. And referring clinicians or PCPs may help patients select an appropriate option using the Access Participant Directory and support enrollment directly with the participant. Access participants will establish connectivity to a Health Information Exchange, or HIE, a CMS-aligned network or equivalent trusted network that can facilitate transparent information sharing and monitoring of clinical data with the PCP and referring clinicians. Next slide, please. So one of the key benefits of Access is that it helps PCPs and referring clinicians stay informed about changes to an aligned beneficiary's health status. So Access participants must securely share information with PCPs and referring clinicians, and this reduces fragmentation and supports more coordinated, continuous care while allowing the PCP and referring clinicians to receive updates on their patients from Access participants. Before sharing these updates, Access participants must obtain the beneficiary's consent to proactively share care updates with their identified PCP and referring clinicians. Clinicians can establish data sharing arrangements to better support care coordination, so long as those arrangements comply with applicable laws, including the Anti-Kickback Statute, or AKS. PCPs and referring clinicians are then able to receive the minimum required updates. Next slide, please. Access enables the PCP and referring clinicians to receive required care updates from the Access participants. The PCP and referring clinicians also have the option to receive additional updates as needed and are encouraged to establish more frequent and data sharing arrangements with Access participants. But at a minimum, Access participants will share updates at key points of care with PCPs and referring clinicians during the following timeframes. One, within 10 days of submission of all baseline OAP measures. So Access participants will communicate the care plan, baseline measures, responsible contact, and the initial care goals. Then within 30 days after the end of the 12-month care period, or sooner if the Access beneficiary is no longer aligned, the Access participants will summarize the outcomes achieved, the medications, and any follow-up recommendations. Lastly, within 10 days of any transition of the Access beneficiary to another practitioner or care setting due to clinical needs exceeding the scope of Access services. So to reiterate, these are the minimum required care updates intended to avoid overwhelming the PCP with excessive notifications. PCPs can additionally bill a special access code for reviewing these care updates, in addition to other codes that we will go over shortly. Next slide, please. As mentioned previously, the access model requires participants to document specific details in the care plan to ensure that coordinating clinicians continue to be well informed about their patients. So the care plan template will include the following elements: details on the patient and sender information, including the beneficiary's name, date of birth, the access participant's contact details, monitored clinical contact, and the medical director's name for oversight. This template will also require information about the beneficiary's aligned clinical track or tracks, qualifying condition or conditions, care start date, and applicable OAP measure values. Additionally, the plan will document a beneficiary's medications and symptoms, the participant's plan for treatment, including any lifestyle interventions or symptom relief, and planned follow-up for when the participant plans to collect the next round of access beneficiary's clinical data. Lastly, the plan will have guidance on CMP billing for PCPs and information about the model. As stated previously, participants must transmit these care updates through a HIPAA-compliant secure electronic method. You will be able to find the care plan template on the CMS website, and we'll also be sharing the link in the chat. So now I'll pass it over to Coleman to go over the next section on the co-management payment. Next slide, please.
Thank you, Anna. Now we will discuss the access model's co-management payment approach. Next slide, please. To support ongoing care coordination and encourage continued engagement between referring healthcare providers and access participants, eligible clinicians who co-manage access beneficiaries with an access participant and review an access care update for that beneficiary and track may bill a new access model co-management service. The co-management payment, or CMP, is payable for 1 unit of service, requiring a minimum of 5 minutes of clinician time spent reviewing an access care update and performing any associated care coordination activity. Eligible Medicare Part B clinicians include physicians, physician assistants, and other provider types listed on this slide. Next slide, please. We plan to allow the following entities to bill through Medicare Parts A and B beginning in October of 2026. These entities include federally qualified health centers, or FQHCs, and rural health clinics, or RHCs, who would be eligible to bill through Medicare Part A, as well as pharmacies and medical supply companies with pharmacists who would be eligible to bill through Medicare Part B. These entities are in addition to the providers already eligible to bill the co-management payment beginning in July, as outlined on the previous slide. Next slide, please. Clinicians who are eligible to bill CMPs can receive established payment amounts per service at a defined billing cadence. Clinicians may continue to bill non-access services as normal, and importantly, beneficiary cost sharing does not apply to the CMP. The CMP is payable up to 3 times per 12-month care period per beneficiary per access track. Clinicians may bill CMPs for different tracks for the same beneficiary when distinct review and care coordination activities are performed for each track. CMPs will be paid $30 per service, subject to geographic adjustments. Additionally, as mentioned previously, clinicians who assist a beneficiary with onboarding and initial setup activities may also bill the co-management payment code with the CMS specified modifier the first time they bill for that beneficiary. Clinicians will be eligible to receive an additional payment of $10 for that onboarding service. Lastly, and to reiterate, CMS will pay 100% of the Medicare allowed amount for co-management payment services because CMS is not applying beneficiary cost sharing to the CMP. Next slide, please. As mentioned, to bill the CMP, the eligible clinician must review an access care update and complete at least one related care coordination activity, including adjusting or reconciling medications, updating the problem list, establishing, modifying, or monitoring follow-up instructions, coordinating care among clinicians involved in that beneficiary's care, communicating with the access healthcare provider, documenting clinical agreement or disagreement with access recommendations, or a referral. Additionally, as mentioned previously, the initial onboarding payment is for access beneficiary enrollment support and device or application setup, including supporting the beneficiary in identifying an appropriate access healthcare provider for their needs, supporting enrollment with the access healthcare provider, educating the beneficiary on the access healthcare provider's role, assisting with device application or data sharing setup, or confirming successful initiation of data transmission and engagement. The HCPCS G-codes on the slides are specific to each track a beneficiary would be aligned to. The initial onboarding payment modifier may be billed for each beneficiary and track combination, provided that onboarding support and application setup were rendered. Next slide, please. Eligible providers should follow required billing guidelines to support accurate co-management payment billing and payment. Each CMP claim must be backed by documentation showing the billing clinician reviewed the clinical update electronically shared by the access participant. First, the date of service must match the date of the documented review and care coordination activity. Additionally, the place of service code must reflect the reviewing clinician's practice setting, including telehealth settings as applicable. The diagnosis code must correspond to one of the qualifying conditions for the beneficiary's access track. This is especially important because HCPCS G-codes without a condition corresponding to the correct access track will be denied. You may refer to the artifacts page in the implementation guide, specifically section 3.0.2.4 value sets, to examine the track-specific diagnosis codes for the access model. Next, the rendering clinician on the claim must be the Medicare-enrolled professional who performed the documented review identified by NPI. The PCP or rendering clinician's practice TIN and NPI must also be reported as the billing provider. The referring provider is an optional field on co-management payment claims. CMPG codes and initial onboarding payment modifier amounts will be adjusted based on the Medicare physician fee schedule geographic adjustment factor, so actual payments may vary from the national rates based on each eligible clinician's location. I will now pass it back to Pooja to facilitate today's question and answer session. Next slide, please.
Thank you, Coleman. We'll now begin the Q&A portion of today's webinar. Next slide, please. Thank you all so much for your engagement throughout this presentation in the Q&A box. We'll now answer some questions, including those submitted from your registration forms. All right. Anna, I'll pass it to you.
All right, we're going to start with some questions relating to referrals. So the first one for you, Pooja, is how can patients participate in access? Do they have to go through their PCP or another referring clinician?
Thanks, Anna. Patients with Original Medicare can sign up directly with participating access organizations and can enroll in different tracks from the same or PCPs and referring clinicians can optionally assist with enrollment, but this isn't required. Clinicians who assist beneficiaries with setup can add that modifier that Coleman talked about to the co-management payment billing to receive an enhanced payment. That modifier is the AC modifier. CMS will maintain a public directory called the Participant Directory, which will include all access participants, including the conditions they treat and the risk-adjusted clinical outcomes, so patients and providers can make informed choices.
Thanks, Pooja. What will the Access Participant Directory be used for?
The forthcoming Participant Directory is intended to give beneficiaries transparent, accessible information on access participants so that they can make informed choices and compare organizations based on available tracks, treated conditions, and risk-adjusted outcomes. This participant directory is available for both beneficiaries as well as primary care and referring clinicians. And once available, the participant directory will be linked on the model webpage. Beginning fall of 2027, CMS will also publish risk-adjusted outcomes for each organization in the Access Directory and at data.cms.gov. Just want to note here that it'll take some time for these measures to be calculated and for the risk adjustments to be made upon them, which is why this information will be coming fall of 2027.
Awesome. And if a PCP refers a patient to the access model, does the access model participant still need to verify clinical eligibility?
Yes. Access model participants will need to confirm beneficiary eligibility using the CMS eligibility and alignment APIs, two separate APIs. After eligibility is confirmed, they will collect baseline clinical measures, which could include blood pressure for patients with hypertension, for example, to ensure that we're tracking improvement over time.
Next question, will access participants be able to refer patients to a PCP if the patient does not already have one?
This is a great question. Yes, access participants are expected to identify at the time of enrollment the beneficiary's existing PCP or referring clinician and document those steps. Just to walk through these steps a little bit more, the requirement is met when the participant first asks the beneficiary during enrollment to provide the name and, if known, contact information of their current PCP and any clinician who referred them for access services. Second, the participant must review any CMS supplied information, if made available at the time of alignment, which could include Medicare providers or suppliers associated with beneficiary. Third, which is the optional step, the participant must review clinical data, so for example, from an HIE, to identify the beneficiary's PCP or referring clinician. And fourth, the participant must document all steps in the beneficiary's record. If the beneficiary doesn't have a PCP or one can't be confirmed, that requirement is considered met. In this situation, the participant can then refer the patient to an in-person or telehealth provider for primary care management, so long as the referral is not made to an affiliated organization and all applicable federal and state laws are followed.
Thanks, Pooja.
All right, so now I have a couple questions for you, Anna, regarding care coordination. The first question here is for escalations to the PCP and data sharing, is it sufficient to send information back to the primary team through an HIE push from the EHR systems using automated protocols?
Potentially, yes. CMS has published to the model web page the care update template, which we've also shared in the chat, and that outlines the information that participants will be sharing with PCPs and referring clinicians. If the information is communicated clearly and includes everything CMS requires in the care update template, participants may use the method that works best for communicating with their PCP.
Great. The next question is, how should clinical data and reporting flow from an access model participant to the coordinating clinicians?
Access model participants should support care coordination by identifying aligned beneficiaries, existing PCP and/or referring clinicians, and sharing those standardized clinical updates with them at key points in patients' care journey. So that's at care initiation, which is including the care plan and baseline measures, if there's any clinical escalation, and then at the end of each care episode. Participants should use HIPAA-compliant secure electronic methods to transmit patient data and care updates, and this includes direct secure messaging, a health information exchange, or secure electronic fax.
Great. The next question in this category is, when do systems for bidirectional HIE updates from the PCP or referring clinicians need to be in place?
Participants should establish or maintain HIE connectivity by July 5th, 2027, which is 12 months after the access model start date of July 5th, 2026. That connectivity should support bidirectional electronic exchange of health information across the geographic areas where the participant delivers their care.
Our next question is, can CMS clarify the operational expectations for behavioral health organizations serving as the lead care coordination entity?
Great question. So, like other PCPs and referring clinicians, behavioral health specialists and organizations with aligned access beneficiaries will be expected to have the infrastructure and operational capabilities needed to carry out the access model requirements effectively. This includes coordinating across clinicians, including behavioral health clinicians, strengthening measurement and reporting capabilities so access participants can track progress in real time, and assessing how existing roles and workflows align with the model requirements. Organizations would also need to verify that their reporting infrastructure can support required data collection and submission, with IT systems able to produce data outputs in the formats and timeframes needed for access reporting.
Awesome. So our last question in this category is, can a PCP or referring clinician bill the CMP without receiving the care update?
No. So if a PCP or referring clinician never receives a care update from the access participant, they would not be eligible to bill the co-management code. To bill the CMP code, a clinician must review the access care update and place a brief written note in the EHR documenting the assessment and any care coordination action such as medication change or reconciliation, updating the problem list, monitoring instruction, or referral.
Awesome. Thank you so much, Anna. I'm going to turn it over to a few billing questions that we've collected. And for that, Coleman, I will be asking you those questions. The first is, how often can I bill the CMP or the co-management payment?
So that's a great question. So a physician, a PCP, a referring provider could bill up to 3 times per 12-month care period per patient per access track. And so that's important because if a patient is enrolled in multiple tracks and you perform those distinct coordination activities for each track, you could bill separately for each track.
Awesome. Thanks, Coleman. The next question is, how does the billing process differ for PCPs and referring clinicians?
Sure. So the billing process does not differ for PCPs and referring clinicians, and I think this will help also answer some of the questions in the chat in the Q&A. So both PCPs and referring clinicians who co-manage access beneficiaries with an access participant may bill the new access model co-management service for documented review of access updates and relevant care coordination activities. The access co-management payment G-code modifier and additional billing guidance will be shared later this year.
Awesome. Thanks, Coleman. The third question is, if primary care providers or practitioners bill any of the HCPCS or CPT codes on the substitute spend list, does that mean that the access payment will be adjusted downward?
So this is a little bit complicated, but the short answer is not exactly. If you are the access participant or an affiliated entity, you cannot bill Medicare fee-for-service for aligned beneficiaries during active care periods. This includes the co-management payment code. I know we've gotten a couple questions around, can the PCP be the referring provider and billing access provider? So the fee-for-service exclusion here would actually, if the PCP is the access participant, exclude that PCP from billing any other code other than the access G code. So if you are a separate provider and bill for the service on the substitute spend list, aka you are a provider not affiliated with the access participant, those claims could count against the access participant substitute spend rate. The claim would still be paid, but it could reduce the participant's payment if the rate falls below the required threshold and one of the primary diagnosis codes on the claim matches the condition for which the beneficiary is enrolled in the access track.
Wonderful, thank you. Our next question is, does the OAP replace what a PCP could normally bill fee-for-service for chronic care, or is it an added payment to help cover technology and co-management support?
So the outcome aligned payment, or the OAP, is a full replacement payment and not an add-on payment. So if an organization is an access participant or affiliated entity, it cannot bill Medicare fee-for-service for aligned beneficiaries during the active care period outside of those OAPG codes. So to reiterate, that payment is meant to replace fee-for-service billing for those services and not supplement it.
Awesome. So the last question that I have in this section is, how does billing new care coordination codes for certain care coordination activities under Access affect PCP's ability to bill collaborative care model or COCM codes?
This is a good question. PCPs and referring clinicians can bill Medicare for the Access co-management payment when they review care updates from the Access participants. Access does not change their ability to bill for other Medicare services, including COCM. So as long as the PCP is not part of the organizational TIN that is participating in Access, they could continue to bill those codes.
Awesome. Thanks, Coleman. We will now open it up to some of the questions that we have received over the Q&A. I will start with a few and then pass it to some of my co-presenters. The first is regarding whether participants can send encrypted messages and eFax to providers. Just to directly answer that question, participants must meet the PCP or referring clinician where they are. So whatever encrypted messaging is preferred for that group or entity. This could include encrypted messaging, or it could include eFax or another secure method. Another question that we received is whether the access participant can be the same as the PCP. So just to directly answer this question, no, the access participant cannot be the same as the PCP for one given beneficiary. There's no prohibition against PCPs or referring clinicians being access participants, assuming that they meet the eligibility requirements. But that being said and set aside for a moment, when a PCP is the access participant, they can't also bill the access co-management payment for their own access aligned patients. This is due to the model's fee-for-service exclusion policy, where a participant of access billing an OAP code for a given beneficiary cannot bill fee-for-service for that beneficiary, and the co-management payment is effectively fee-for-service. Another question that we received in the chat is whether patients can sign up for access directly or if a clinician needs to sign them up. We mentioned this earlier, just to say again and to be explicit, patients can sign up directly for access. They don't need to rely on a referring clinician to sign them up directly. Though, of course, that's encouraged as we want to ensure that the healthcare ecosystem is maintained and all support channels for that beneficiary are aligned. Ultimately, the patient can sign up directly for access. And as I mentioned earlier, or as one of my colleagues has, the access participant is required to identify a primary care provider or referring clinician for that patient. So there's always that assurance that an individual is connected back to the patient outside of just the access participant themselves. The last question that I will group together in this bunch is one that we received regarding the large number of access participants. And the question in particular is how primary care providers are going to know whether a participant is the right fit for their patient. The participant directory is really going to be that chief critical piece of information or tool here. The participant directory will contain information about each participant, including the tracks that they're participating in, information on their treatment methods, and other related information. And there'll also be a filtering capability involved there to hopefully help support a bit here too. This will be a critical resource for primary care providers to use to identify the best access participant for their patient. I will now pass it to Coleman to run through a few questions too.
Perfect. Thanks, Pooja. I think we're going to group a couple of questions together around what provider types are eligible to bill for the co-management payment. There's a full list. The slides will be shared in the proper manner, but I believe it's slide 19 goes through those provider types. And so I think the question was around physical therapy. Would a PT be considered a referring provider if they decide a patient is appropriate for digital care? And so the answer there is a physical therapist is eligible to refer beneficiaries to access and bill the co-management payment for that referral and ongoing care coordination. A similar question was also asked around registered dietitians, and the same answer there. If they're on that list of approved specialties or clinician types to bill the co-management payment, those claims will be processed. We got a question around what is specifically meant by a CMS-aligned network. And so the answer there is that a CMS-aligned network is a voluntary health data exchange network that commits to meeting CMS's interoperability framework criteria for sharing health information among patients, providers, payers, and health technology applications. CMS designates networks that self-attest to meeting these criteria as CMS-aligned networks. The next question, and I think it's an excellent question, is will there be a discount taken to the co-management fee for NPs and PAs? We're really excited to announce that any of the provider types that bill for their co-management payment will not receive the traditional discount, whether that's 85, 80, 75%. All of those payments will only be adjusted by the relevant Medicare physician fee schedule geographic adjustment factor. The next question to answer, sorry to keep going here, can more than one physician submit a claim for co-management of the same patient? So the example there is a primary care physician and their cardiologist. The answer there is yes. So provided that all of the steps are followed in terms of reviewing the care update and performing those care coordination activities, your cardiologist and PCP or any other specialty type could perform a co-management payment service to the same beneficiary for the track that they're enrolled in. Well, let me see what else. Pooja, I might pass it back to you before I collect my thoughts for some others.
That sounds great. Anna, I was wondering if you might be able to go next.
Yeah, I saw one in the chat that was asking how will access participants work with PCPs to ensure the care interventions or prescription changes are appropriate for the patient and align with the patient's existing care plan. And as mentioned earlier, the access participants will be required to electronically share care updates with the PCP and referring healthcare clinicians. And we believe that that structure is designed to support the integration of care delivered by access participants into the broader healthcare system and collaboration with healthcare organizations. And as also mentioned earlier, the requirements for the access participants are the minimum required interaction. So once that has been established, PCPs can engage with the access participant more regularly as needed. And I'm looking if anybody, if Pooja or Coleman have any others that they wanted to answer
Yeah,
live.
I can totally go next. There was one question about how referrals would be reconciled with Stark laws. The question continues, if a health system partners with an access clinic, and then if that clinic sends the patient back to the health system for escalations, would that be a concern? So I just want to flag here that the model is not waiving the anti-kickback statute, so that absolutely is something that should be considered when making referrals. We also have a consideration of financial affiliation that should be factored in as well. These two pieces of information can be found in the request for applications, and I encourage folks to take a look there and consider how these rules and regulations apply as you consider participating in access, either as a direct participant or indirectly as a primary care provider or referring clinician. Another question that we got is whether the program applies for patients age 0 to 18 or patients 18 or older. So want to just flag here that the access model, it has certain eligibility considerations, including eligibility for Medicare Part B. These eligibility considerations can be found in the request for applications. There are also track-specific considerations to consider as well. Um, Specifically there, the beneficiary cannot be in uh, or receiving dialysis for end-stage renal disease or ESRD if they are in the CKM and ECKM tracks. Um, Behavioral health beneficiaries also may not be enrolled in a certified community behavioral health clinic or CCBHC program. These are additional considerations that we encourage you to take a look at. Again, all of this information is in the request for applications, including more detailed information on eligibility. Anna or Coleman, any other questions to group together?
Yeah, I can answer a couple. We had one that was if a patient is referred to the program by PCP, does the beneficiary still need to enroll or will it be automatic enrollment? And we want to stress that the alignment is voluntary and prospective, with patients aligning or enrolling with an access participant directly. So referral alone will not enroll a patient with an access participant. The access participant will verify the coverage with the CMS Access Eligibility API. And then the participant is responsible for validating that the beneficiary meets clinical eligibility requirements for the track. And then before initiating alignment, the access participant must obtain and document the beneficiary's informed consent. So that consent must be provided verbally or in writing and may be documented in the patient's record. So just want to stress that consent is especially required before a patient begins care with their participant. The other question I had was, does an access participant need to establish care with the patient? And yes, access participants are expected to deliver care that is reasonably designed and implemented in good faith to be safe, high quality, and consistent with nationally recognized clinical guidelines and standards of practice. And so care initiation is an important part of the access participants' care delivery requirements. Coleman, did you have any others that you wanted to?
Yes. There are two questions around the timing of the co-management payments as it relates to the two sort of different groups of providers we've been talking about. Everyone who is not an FQHC, RHC, or a pharmacist can start billing the co-management payment the second the access payment program goes live. And then come October of this year, October of 2026, those grouped out provider groups will be able to start billing. So pharmacies, FQHCs, and RHCs will start billing in October of 26. Two sort of questions around how we're going to engage PCPs and educate clinicians on this program. The first is things we're doing right now, right? We're going to hold webinars and engage with stakeholders to spread the word about this program and how you can engage with beneficiaries and participants. And then there was a question specifically to the Medicare Learning Network. We will be using the Medicare Learning Network to, again, spread the word around the access program, and that will be happening shortly. One question around specifically how long do access participants have to demonstrate outcomes to unlock payments, and can you walk through the timing of that? It gets a little bit complicated, but essentially participants have 1 year to improve outcomes or to maintain control depending on the period you're in. Come that year, we'll look at your outcomes and determine whether you met the required metrics, and then that will dictate the payments you get. One question on if a beneficiary has gone through and finished standard fee-for-service physical therapy a few months ago, can the participant still enroll for access in the MSK track? The answer there is yes. So you can enroll in the Access MSK track with a participant as long as you haven't enrolled with them already in a certain time frame. And so that's the short answer. I'm going to pass it back before I collect my thoughts for others. Pooja.
We're happy to take a couple. All right, let's see here. There's one question, how will PCPs and clinicians find out about the access model? We are hoping that this is one avenue to learn more. We also will be sharing information across a couple different other platforms, which may include the Medicare Learning Network, among others. So more to come on that. We hope to continue to engage as well with stakeholder groups to continue to spread awareness on access. All right, what else?
I have one I can answer. There is a question on how are access participants acquiring patient contact information, and access participants may engage in direct outreach to potentially eligible beneficiaries. Of course, that's in compliance with standard CMS marketing rules. And then beneficiaries may decide in their own discretion which access participants to contact if they are interested themselves in the access model.
Thanks, Anna. I also see a question in the chat. If I heard correctly, PCPs cannot bill the CCM or ACP or sorry, APCM the same month. And I just want to clarify that the CCM and any other fee for service can be billed simultaneously. There's no restriction there. The restriction is the one that I mentioned at least is the fee for service exclusion, and this exclusion is placed on access participants. So if a participant of access bills the OAP, which is the payment, the critical payment under the access model, they are not able to bill any other fee for service. And falling within that category of any other fee for service is the co-management payment. So just want to clarify that point, but feel free to ask any more, any pushback or any follow-up questions if helpful. There is a question about when the next selected cohort of the access model will be announced. Our next step is releasing the participation agreement, which is soon to drop. Once that participation agreement has been sent and reviewed by folks who have received that agreement, once those individuals sign, they become participants, and we will be able to release those names publicly. After that point, we have effectively quarterly opportunities to participate. The next opportunity is technically January of 2027 and then quarterly thereafter. More information on that is in the RFA, just in case at all helpful to reference. And I think I tackled a couple questions in that. Coleman or Anna, do you want to tackle any others?
Yes. I'll happy to take one specifically around diagnosis codes, and I know we sort of mentioned diagnosis codes a couple of times. This question is, does it mean as long as the primary diagnosis code billed by the PCP, then the same diagnosis code is performed by access model participants impacts the OAP? So we've sent a link to the implementation guide, which has a full list of diagnosis codes within each track. To receive the co-management payment, you have to have one diagnosis code for the track you're billing for. It does not have to be the diagnosis code for which the access beneficiary is aligned to the participant. For the substitute services list or substitute spend list, if you're a clinician participating outside the access model and you bill a normal E&M code that's on that list, the diagnosis code that you bill there has to match the diagnoses for which the access beneficiary is aligned to the model. So there's a small nuance there, but for the co-management payment, put one of the diagnosis codes on your claim that matches one of the diagnosis codes on the implementation guide.
And then I see a follow-up on the participant directory. How are PCPs going to access this? How will it be made accessible? On this question, the directory itself is forthcoming. It does not currently exist. However, we will link it to the model webpage. We will also make sure that we are taking advantage of different distribution channels, which could include the MLN or others, Medicare Learning Network, just to clarify that acronym. More information is forthcoming. We will be sure to connect with groups to ensure that this is widely distributed, however. And then I think maybe one last question. There was a clarification on whether different physicians can bill the CMP for the same patient and track. And just to say, yes, different physicians can bill the CMP for the same patient and track. I think with that, we have answered as many questions as we have time for. Really appreciate the engagement. And we'll just now go over some brief closing remarks as well as some resources. To learn more about the Access model, please visit the Access webpage, which is in this chat. The Access webpage has important information and will house upcoming resources such as the CMP billing guidelines and the participant directory, as I mentioned. As a reminder, these slides, transcript, and recordings will be available on the model webpage in the coming weeks. And if there are any outstanding questions, we welcome everyone to email them to the model team via the help desk email. We'll use the questions received during this event and via email to inform updates to the model's FAQ webpage. Next slide, please. And finally, we just appreciate so much if you could take a couple of minutes to fill out the post-event survey. Your browser will direct you to the form after this event. As always, we look forward to continuing to connect with you all, and this concludes today's event. We hope that this information was helpful, and we really appreciate you joining us today. Thank you.